My name's Andrew Jamieson. I'm from WACHS. My current role in WACHS is I'm one of the executive directors of medical services. My background is rural general practice, and in another life, remote and infectious disease and travel medicine. I am fellow of the Australian College of Rural and Remote Medicine, and I am very conscious of the role that generalists play in providing emergency services. And at the same time, I'm deeply grateful to our specialist colleagues who I think are more and more aware of the challenges of providing emergency services in remote locations. I'd also just like to acknowledge the elders and traditional owners of the land on which we meet. The Whadjuk people of the Noongar Nation, acknowledge elders past, present and emerging, and also any Aboriginal or Torres Strait Islanders present here today. So the other thing about this is that I've got my Kevlar bulletproof vest on under my shirt. I know that when one comes representing a health service provider, that there's always some questions that some people might feel they want to ask, and I'm quite happy to take any questions from anyone. We've got, I think, about half an hour scheduled. I've got a presentation that I'll go through. I'm not going to go through it in a lot of detail because I think I want to save some time for questions afterwards. Thanks very much. And also, please feel free to ask as we're going along. So I'm going to start off. I know Mark said to me he spoke this morning about credentialing and some of the aspects of clinical governance. And I just want to talk a little bit about credentialing because it's in terms of the systems that we use and the requirement that we have to make sure that our clinicians, and particularly our medical clinicians, our doctors, are appropriately skilled and qualified to work in an environment. Well, unfortunately, credentialing is a necessary thing that needs to happen, and we manage credentialing. Obviously, there's a policy and there's a fair amount of science behind it in terms of assessing people's skills and experience and qualifications. But we manage it through a database which is called Credwar for obvious reasons. But it's a commercial package which was developed by an organization called Equifax, and it's cloud-based. It's quite convenient in that people can access it. And I'm sure if you're all credentialed or have worked with any of the government agencies, you're aware of the front end and the back end of it. The front end is the part that you own and the part that you put all your own information into it. So that's around things like qualifications and experience and CPD and all of those things. And then there's the back end, which is the part we use to process the information that comes to us. This Credwar system is shared by all health services providers. So if you're on it and are a doctor who has gone onto it to work, say, at Fiona Stanley, you'll be on the system. And we can see quite a lot of what's on the other health service providers, but not everything. But the same system is shared across all health service providers. But one of the issues around the use of this database is that, first of all, it does have its bugs. And because it's used across a number of HSPs, fixing the bugs can sometimes be surprisingly tricky, because what we call a bug, another HSP might quite like, in terms of it being locked down, for instance. So while it's not necessarily an excuse for some of the clunkiness and the difficulty of it, it is maybe a reason. So we're quite aware of a number of issues that make people's lives difficult sometimes around the credentialing system. For instance, wax-wide credentialing. The theoretical principle that if someone is suitable for independent practice, independent emergency practice in Headland Health Campus, that they should be suitable to work across the whole organisation, we definitely accept. There are some nuances to it, obviously. I think running the ED at a place like Bunbury, after 10 o'clock when the emergency specialists go home, 10 o'clock in the evening until 8 o'clock in the morning, is different to working in a small town in the wheat belt, in terms of just the level of activity and the likelihood of referred in acuity that occurs in that environment. One of the problems that we have around the structure of the system is that to move people around within the 7 regions of WACHS currently requires permissions because of the privacy constraints that we have within our ICT environments. Sometimes we can't just change things, it requires the consent. And this is, again, not an excuse, but it is a reason. This is one of the reasons why sometimes it's quite hard to get credentialing transferred from one region to another, is because it requires the permission of that person who doesn't necessarily have to change anything, but they have to receive it and then send it back to us. So we're working on changing this, and one of the ways that we can change it is that the first time someone is credentialed with us is we will probably credential them as widely as we can across the whole system so that we don't have to amend these things going forward. The other thing around it is around recording information. So it's things like CPD. If someone's done a course, if they've done ALS2, one of the problems is that unless the individual scans that certificate and puts it on the system themselves, it's not visible to the whole system. If they send the system to us as an email and say, please put it on the system, we can put it on, and this is a bit technical, in a section called admin attachments, but that's not visible to anyone other than us. So this adds, unfortunately, to the clunkiness of it, and it's one of the reasons why we ask people to do strange things, and please put it on yourself. So in terms of the design enhancements, we are working our way through all of these, and I would think within the next year or so it's going to become a lot less clunky. Just a bit of insights. We're talking about systems, about our safety and quality systems and how that impacts on everyone now. So one of the basic principles of measuring quality is that we try and do things that give us an opportunity to look at prospective safety indices. And one of the best ways to do that still is doing audits of practice. So just seeing what people are doing in their normal course of events to see if there's anything that we need to change. If you look at retrospective safety and quality indices, and particularly quality indices, that tends to be around clinical incidents that have occurred, which is obviously that horse is bolted. So we're moving now towards the ability to do audits and live reviews, and there's a new tool out called COBRA, which enables audits to occur on a regular basis around what's going on around people clinically, and every now and then you might see someone with an iPad or another device recording activity. And this information is immediately available on a dashboard to the whole system, and it has already given rise to a number of changes. There are various other things, increasing use of huddles, all the way through to WACHS-wide forums, particularly around quality issues. I know Datix as a collection tool for adverse events is sometimes pretty hard to fathom, and maybe I'll talk a little bit about that. But inherently, it's important for us to be able to look at clinical incidents. But as I say, we'd like to move away from a retrospective approach to a prospective approach. Our data that we collect out of all of this sits in two main areas. We have an area where we keep our quality metrics ourselves within WACHS. There's also a fair amount that the Department of Health keeps. The other thing that's important, just to let you know, is that we are looking at realigning our whole safety and quality strategy to two major premises, apart from a lot of the other stuff that we have been doing. Two of the new premises. I don't know if anyone's familiar with what's called learning health systems, which in a data-driven era enables changes to occur much more quickly, and high reliability organizations, the principles of high reliability organizations. One of the things that we are getting better at is we're starting to produce real live data. Now this is around inpatient fall separations, and if anyone has any experience of using statistical process control charts around standard deviations from the norm, it's quite hard when you've got small country hospitals with relatively small numbers to see how well we're doing. And if you look at this is an analysis of falls, but I think it shows quite well. There's a fair amount of movement of what's occurring, but generally they tend to stay within the standard deviation numbers. So just really wanted to illustrate that. Similarly, in terms of recognizing and responding to acute clinical deterioration, which is a persistent issue in all health services. These are the patients that we just don't detect who are getting worse. The little old lady with sepsis, little old lady who comes in with UTI and slides into sepsis. That kind of patient is that. So we monitor how well we do that. And this is highly retrospective at the moment, and we're looking to improve our prospective tools in this area. But generally, the performance is, in some areas, certainly there's some improvement. If you look at the bottom right metric here, which is where required was all care escalated appropriately, you see we've still got some way to go, because we're sitting at an average of about 80% right now. But actually, do we only want in only 4 out of 5 cases for us to respond to someone who appears to be deteriorating? So there's a bit of work to be done in those places too. Just a couple of words around a major opportunity for improvement that we have across our health service, across the whole health service, and in fact worldwide, is getting the balance right in terms of what's generally known as a just culture, acknowledging that most clinical incidents that occur are not anybody's fault. They are a result of a system that has got some inherent issues that cause adverse events to occur, through to the other side of the spectrum, where either through negligent or, heaven forbid, sometimes willful behavior, that things don't happen that should happen, or happen that shouldn't happen. And for us, the challenge is finding that balance. And I think that we're very conscious of the fact that the just culture approach is the predominant approach that we absolutely need to take. But there's no doubt that we need to maintain accountability and individual clinical accountability for people's decisions that are taken. There is an issue at the moment with legislation here in Western Australia. The Healthcare Act of 2016 sets the bar very low for reporting to the healthcare regulator around clinical incidents. And there's a very strong movement to changing that. There's a legal requirement on health service providers in terms of that. So that's it. We all have a concern around that, and there will be some work. There is already some work occurring in the change of legislation. More in the area of corporate governance, which impacts obviously on clinical issues. And if any of you work for WACHS, you'll know that there's 2 ways generally for doctors to work. The one is to work as an employee, and that's under the terms and conditions of the AMA-mediated enterprise bargaining agreement. The other one, if you work for us, you work on a medical services agreement, which is a contractor agreement. So there's not an employment relationship, there's a contracting relationship. And there's a fairly standard contracting document that is used. People are remunerated if they're working on an employment arrangement through a salary, and working as a contractor through 2 major ways, either within a fee-for-service environment, sometimes with other ancillary payments, or on a time-based. So some people get paid on a daily basis. Next year is the contracts will all be renewed, and there'll be the usual rounds of discussion and consultation around what those contracts are going to look like going forward. The one thing, though, that we have a problem with from the Australian Taxation Office and a number of other people is what I would call pseudo-employment. We have people working on MSAs for prolonged periods without breaks. And interestingly enough, most of the time that pressure comes from people who work for us on contracts, as opposed to people who through their choice rather than through us wanting to employ them. But the problem is that if the Australian Taxation Office deems that people are working on contracts to avoid the payment of tax on a pay-as-you-go basis, then it does cause problems. And the other thing is that payroll tax, which is a state-based tax, is not paid for people who work on a contractor base. And so the state becomes quite edgy around the non-collection of payroll tax. And the other one that we get is, excuse the typo, around superannuation for people who work regularly. Theoretically, the amount paid to people working on a contract takes into account that they're not getting any of the standard benefits. But it is a concern for various people. So it's really important to understand that there is quite a lot of risk if people work on an ongoing and very regular basis without any significant gaps on an MSA, that organizationally and personally we can run into compliance issues. I don't expect you to be able to see that because I definitely can't see it, but the other thing about systems that I thought is worthwhile just chatting about is the clinical services framework. If you've never heard of what the CSF is, the CSF is the policy document which sets the level of service that all hospitals should provide. And this informs a whole lot of things. So this informs what Treasury should pay the organization to provide that service. So if you look at the top table, there is across South Metro, North Metro, and statewide, and looks at the level of care provided by emergency departments. So you'll see Fiona Stanley is a level 6. Now, the WACHS is there 1, 2, 3, 4, 5 regions across the bottom. You won't be able to see that, but I've done a little bit of a blow-up of, for instance, the goldfields here, in terms of what that means. So, for instance, Kalgoorlie as a regional resource centre is a 4, Esperance is a 3, Leonora, Laverton and Norseman are 2s. And it is quite well set out what the requirement is in terms of the service that is likely to be provided there. And I think the reason why I'm highlighting this is I think that it is sometimes important for people to know that the level of service that is provided in the country is restricted often through policy and through the provision of funding by the clinical services framework. So WACHS, in an attempt to deal with the very limited ability of the CSF to deal with the nuances of the country, we have an additional capability framework called the Emergency Care Capability Framework, where we've just looked at categorizing our services into nursing post with a local GP, small town hospitals, and the different size emergency departments. And you can see this basically sets out what should be available, and also incorporates how we use telehealth to support those sites. And this ECCF, the Emergency Care Capability Framework, is available on the internet, so you can Google it and you will find it there. It's quite an interesting document to read. The other component around this governance is that it does describe minimum equipment. It looks at medication imprests and looks at the governance arrangements. And one of the things that we're moving towards is in our larger emergency services, the increased use of emergency specialists at a governance level. And many of you who work in emergency departments where maybe you haven't had too much to do with emergency specialists will notice that you're starting to see more and more emergency specialists involved in the governance of that department. So this is a famous TV story that you might remember from, I don't know, about 18 months ago of a remote area nurse at Coral Bay who had an acute coronary syndrome and thrombolized himself with the assistance of the ETS. And this is a picture of B. Skitchitana, who was working for ETS at the time as a FACEM. It was her first shift, and she ended up dealing with this. He thrombolized himself and flew down and actually ended up with a good result. But that segues really into just a level, give you a sense of where we're going with some of these digital support initiatives. And that's what they are. They are really aimed at providing support to two sites. Emergency Telehealth Service, I'm not going to spend too long talking about that. About 6 weeks ago saw its 100,000th patient. And that's very well entrenched and is widely used. Much more in the south than the north of the state. I think the DMO model in the north of the state, where you're pretty much guaranteed a senior practitioner to attend, means that the requirement for assistance through the ETS is not as high, but certainly it's used in all regions and is pretty well universally looked at. We're starting to get requests now. We've just put our first, we're just connected to the first Aboriginal medical service now, and we've had requests from various other more widely situated entities. Inpatient telehealth service has been running now for about 18 months at a low level. It provides a very important service to be able to take over the governance of patients for up to 72 hours when the local GP has left town, or to be able to admit a patient that's seen through ETS where the local doctor isn't there, or there isn't a local doctor who needs to be watched in a hospital for 72 hours and has got a suitable medical condition that allows that person to be watched. So the instance here that I generally quote is palliative care. You've got a really unwell person who's approaching the end of their life. They arrive at an ED, they need to be managed, but there's no local doctor. We're now able to manage those patients, sometimes actually for longer than the 72 hours. It means they don't have to get put in an ambulance and taken 80 kilometers to the nearest town where there is a doctor. So that's made a big difference. The mental health emergency telehealth service with psychiatric liaison nurses, with psychiatrists on call, has made an enormous difference. And obviously outpatient telehealth, which is just kind of normal telehealth, is continuing. Things that are coming out of the command center. So you might be aware that ETS is a component of what we now call the WACHS command center. I've spoken about the emergency telehealth service, inpatient telehealth service, and mental health telehealth service. And just a quick word about the advanced patient monitoring system. This is a system where I spoke earlier about the little old lady with a UTI in an environment where you don't have a lot of nursing resources. People slide slowly into sepsis. For us to be able to monitor people with a meaningful remote monitoring capability that is able to predict. So a lot of they call them EICU systems. They really look at vital signs, constant monitoring of vital signs, and look at early trends. And you can pick up deterioration 6 to 8 hours. So it's procurement because it's pretty expensive, but the procurement process is underway. So to have a full system up and running, probably 9 to 12 months, maybe as long as 18 months. Certainly initially this is around vital signs monitoring. And what will happen is you've got 5 or 6 streams of vital signs, is that there will be artificial intelligence mediated early warning at the bedside, primarily actually, but also monitored at a central location. So what's really important is that it won't take away the site's primary governance of that patient. But it does mean that if you've got a small hospital with 2 nurses and you've had a motor vehicle accident and everyone's working in ED, that you can keep an eye on that little old lady in the back room. So that's... So I don't know if I kept my promise about leaving lots of time for questions, because I can see they're starting to look through the door.
Thank you very much.
Yeah, it's a pleasure.